Thank you. Actually, there's two different lectures. Last year, kind of separated antibiotic overview and then stewardship. So I'll probably do each of these lectures about 40 minutes to get that hour and a half that I have slotted out, taken care of. So this is the. When I did look back at these lectures, I said there's a couple of slides that I duplicated in each of these lectures. So I hit some slides, but if I duplicate them again, doesn't matter. There's no way I could do an antibiotics in 1 hour. There's no bleeping way you could do that, correct? So this is the first 2/3 should be extremely easy review for everybody here. This is medical student stuff, most of it, and resident stuff. But I want to make sure we all get baseline data. The last third, we're talking about one of the more recent combination medications. And I think that's something I think everybody should hear over and over again, because some of those questions will be on the boards. You've seen ahead of time. And then the second lecture will be on stewardship, and we'll talk about that. It's different where we go. So the objectives is to talk about the most commonly used antibiotics, their spectrum, their common adverse reactions, and I'm not able to talk about antivirals, antifungals. I think there will be separate lectures for that in the future. This is a duplicate slide I have in both lectures. This is what we do as ID. We get a good history, and people who know that I really particularly like the social history, because that's something we're known for. Everybody who's watched House, we don't go that far. We don't want to be known for pill popping and breaking and entering and that kind of stuff. But we want to really go after the history and after especially the social history, because those are the things that everybody else forgets, but many times is really vital to the diagnosis of our patients. So we'll talk about, we worry about the location of the symptoms and the infection, risk factors, which we already know, our immune compromised patients that we definitely have. Travel history is something that I think we only get many times. It's sexual history, the time of year, what's out there in the community. We have our little mini COVID in our summer right now going on. So that's got to be your differential for a fever that may be coming from the community. And geography, where have they been and where are you guys now? Are you in Coxie territory? You're not being in Coxie territory, etc. Slide I purposely duplicated. This is my slide. I make it up. This is what I think people do when they prescribe antibiotics. How broad the antibiotics is proportional to what we perceive as the risk of complications if they have an infection, and inversely proportional to the certainty of diagnosis. So if you don't know what the heck is going on and you think the guy's sick as stink, you're going to give him very broad antibiotics. That's what people do. All right? If you're absolutely certain you know what the diagnosis is, once you figure that out, you narrow them down. All right? Or if you have someone who's not immune compromised, risk of complication from missing a diagnosis is not high, you tend to go narrow initially as well. So I always joke to people, as ID, we should be narrowing and narrowing and narrowing, because we should at least get the denominator a little bit better with time as we see the patient, even though the risk may be still pretty high. This is a dynamic process and should be reevaluated daily. And this is what I probably put most for the ICUs, because they are notorious for broad antibiotics and keeping them on broad antibiotics. And so this my mantra to you as far as stewardship. But we should all know where our normal flora. Why? Because many times we get samples and we grow things. Sputum samples. Man, we expect to see strep and pneumo in our sputum sample potential, because it could be normal flora, but it could be a pathogen as well. You need to know what's there, both to figure out how to interpret your cultures, but also to figure out what type of coverage that you may need and what particular pathogen you're dealing with. That goes for wherever you are. Every now and then, once or twice or 3 times a year, we'll get a Neisseria meningitis in our sputum culture. Have a normal person who actually is doing fine, never should have gotten sputum culture to start with. And people were a little bit ballistic because it's Neisseria meningitis, we got to isolate. We don't. This can be normal flora in a small percentage of people. It's just something we need to know about. MICs. Definition of MIC. What does MIC stand for? Minimal inhibitory concentration. All right. So what does that stand for? When you see an MIC listed in that culture, what does that really tell you?
Like the least concentration needed to have the effect of the antibiotic.
It's very close. It indicates the concentration needed to be achieved that to likely affect that organism. But it kind of depends. You can have an MSC to clindamycin or Staph aureus that goes great, but if you have it in let's say your urinary CNS, clindam doesn't get in there, so it doesn't work. The lower the number, people say the better it is. Well, it's not equal. So if you have an MSC of, there's an MSC of 1 for E. coli for Cipro and MSC of 2 for ceftriaxone for E. coli, they both may be susceptible. Doesn't imply that Cipro is twice as effective as ceftriaxone. The numbers change depending on the organism involved and the drug used. Ceftra, for example, is always a high number. People don't really like Ceftra gets a bad rap. I love that drug. I think it's a bad rap. It has a high number of MIC, but if it's less than 1632, it's still very susceptible. But it's a high number, and people don't like to use it because of that. That's not. It doesn't equate that way. Who sets the MIC susceptibilities? So in the U.S., CSI does that. In Europe, it's UCAST. And they, every so often they review. They look at susceptibility patterns. They look at failures, and they adjust those MIC patterns to see what's susceptible, what's intermediate, what's resistance. More recently, we have had some gram negatives with quinolones. MIC has been barred up, so because they probably were set too low. Also, MICs may be a little bit, as far as effectiveness, may be different depending on location. Strep pneumo, to treat bacteremia and pneumonia, you probably don't need higher dose. But if you treat meningitis, you need the MIC. Maybe matters more because you want to make sure that are you targeting enough drug because you know that CNS needs higher doses to start with. So it's the war of man versus bug, or bacteria, well, in this case. So we figured out a lot of the life cycle of the bacteria, and we targeted areas for antimicrobials. The biggest ones we've targeted is like cell wall. All the beta-lactams target the cell wall. All right. So that includes monobactam, that includes all the cephalosporins, that includes carbapenems, that includes all the penicillins. Also includes vancomycin because it goes after the de-alanine cross-linking aspect. We've also targeted protein synthesis, whether that be ribosomal, whether it be erythromycins, tetracyclines, and the like. Protein synthesis with, as far as transcribing transferred RNA, like linase, the DNA gyrates with quinolones. And even some enzymatic processes with, again, Ceftra, and the cell membrane as well. Daptomycin handles a calcium ion exchanging. That causes cell death. So we've gone out and figured out this is how we're going to target the bug without harming the human in giving this drug. Problem is, the bugs always seem to win. This is a depiction of just a gram-negative resistance that could occur. Just go up here. Any antibiotics come in, like carbapenems go in through porins sometimes to get into the cell. Well, all of a sudden they don't have a porin anymore. Sorry, you can't get in. You do get in, but then in the periplastic space, you have beta-lactamase inhibitors. I mean, beta-lactamases that actually break and cleave those beta-lactams, inactivate them before they even get into the cell proper. You can have efflux pumps. All of a sudden, oh, well, heck, you got pores. I'll just pump them right back out. You have those numerous types of antibiotics. So you can actually have overexpression of efflux pumps as more and more exposure occurs to the antimicrobial antibiotic. You can have various mutations affecting the enzymes, targeting the ribosome, targeting all the things, including the enzymatic issues of Ceftra, to develop resistance. Essentially, as many times as you wage war on bacteria, they wage war back by countermeasures. And they figured many countermeasures out. And as you can tell, this is only a depiction of gram negatives. We haven't even depicted gram positives, whether that be the cross-link of de-alanine, or thickening of cell wall and gram positives. There's many mechanisms out there. And over time, we got to be careful. The more exposure we give to these bacteria, the more likely they're going to find a countermeasure eventually to develop resistance. Quick overview of antibiotic classes. This should be like a review. Beta-lactams. Mechanism of action. Again, it works against the cell wall, but it actually inhibits transpeptidases, the the penicillin binding proteins. It actually acts on the penicillin binding proteins. Concept: time-dependent activity, meaning you have to have time over the MICs. Your level of antibiotic has to be above that MIC number for it to work. Once it dips below, it's below the minimum concentration, so it's not working at that point in time. Unlike other antibiotic classes, which we'll talk about in the future. So these tend to be dosed more frequently. Exceptions are ertapenem and ceftriaxone, but tend to be dosed more frequently because that's the way it works. You want to keep it all the time. Its activity, depending on which drug in that beta-lactam class, depends on its affinity to the target of penicillin binding proteins. Its ability to penetrate those pores we talked about. Its ability to actually stave off the beta-lactamase degradation in the periplastic space. So the carbapenems tend to be most stable versus the cephalosporins, and then the penicillin is at least stable in that beta-lactamase periplastic space. And there's different types of beta-lactamases, including carbapenemases that can occur as well in that space. Beta-lactamase, talk about beta-lactamases. What does that actually do as far as coverage? I got two examples with commonly used drug, Unicin with AMP, Zosyn with piperacillin. If you add the beta-lactamase, it improves your beta-lactamase producing gram negatives, but it also improves your staph aureus coverage and your anaerobic coverage. That you got to understand, it doesn't improve other things. It doesn't. Adding Enterobacterium does nothing for Pseudomonas. Adding Sulbacterium to Empicillin does nothing for Streptococci. All right. But it really works. It really was made for these gram negatives. You do gain staph coverage, you do gain anaerobic coverage. But those are the purposes of really initially the beta-lactamase being added to these agents. So the sport overview, this was going back way when I was in med school. All right. We all remember first generation, second generation, third generation, fourth generation. I guess we have a fifth generation. We always remember first generation, high staph aureus coverage. And as you went down generations, tend to go lower, except for our fourth and fifth generation, septerylene, we have actually staph coverage again. And your gram negative coverage went from very little to increasing as you went in general in those generations. And you had Pseudomonas coverage when you had your increasing generation as well. That holds sort of true. And then you had your fifth generation. Actually, do they call it fifth generation med school now? You guys have been there recently? I actually don't know if they did or not. They didn't have that at my time, all right? And I call it ceftriaxone plus vanco. Septerylene. It's equal coverage to ceftriaxone plus vanco. It really gives you no Pseudomonas coverage, but it gives you expanded gram negative coverage just like ceftriaxone does. And it has the added benefit of MRSA coverage. It's labeled, FDA labeled indication. I always say we never use it for FDA labeled indication. Community-acquired pneumonia, we have better drugs for that. And skin and soft tissue infections, we generally have better drugs for that as well. That's how most drugs get into market, is by doing studies in skin and soft tissue, urine, things that are easy to study to get the FDA. And then you can use off-label. It's used as almost all MRSA, theoretically. And we actually have it as a restricted drug at USA, at TGH, because we want to make sure we treat that in reserve for these difficult to treat staph infections. So where's the places of these generations? First generation, skin and soft tissue, Caflex, cefazolin, and surgical prophylaxis. It's our number one drug. Cefazolin is our number one used drug, not duration, but as far as number of people who actually get it in the hospital, just for surgical prophylaxis. It's great. It's great for that. The lost generation, the second generation. I call it the lost generation because I used to use it a lot. When ceftriaxone used to be my go-to pneumonia, COPD exacerbation drug. But ceftriaxone orally is probably used more than anything else. And then cefoxitin's, it's a vestige of what it used to be. I think it's still used in PID, although other drugs are used. I think cefoxitin is used more in NTM infections than it is actually in PID anymore. It's the lost generation, I call it. The third generation, I call it the internal medicine or hospice drug. It's the go-to drug, ceftriaxone. Boy, that drug's great. It's covered CAP, HILO, SCP. You can use it for meningitis, So internists feel very comfortable using that. It's their workhorse drug for that. The fortunate issue is the ICU workhorse drugs, and then maybe also oncology. You have Pseudomonas, and you cover nosocomial infections because you have drugs that now cover Pseudomonas, like cefepime. And the fifth generation that we just went over, its indication is one thing, but its use is actually for MRSA. That's cephalosporins in a nutshell. Carbapenems. There's 4 of them that I know about. Ertapenem, imipenem, meropenem, and doripenem. Has anybody used doripenem here? We used to have it on formula at TGH. Got rid of it about a decade ago. Cost. The first 3 I put similarly up there because they have similar coverage. They're very broad active, cover ESBL organisms. You know, one thing you gotta know, carbapenems generally do not have great enterococcal coverage. They think they do, but they don't. Out of the 3 up there, which has the best enterococcal coverage? Imipenem does. Most hospitals have only 1 of these on formulary. It's usually meropenem. We have imipenem as well for the unusual infections, we'll call it. The NTM infection, maybe nocardia, things like that. Excellent anaerobic coverage. So the one thing I think the carbapenems, really are known for as well as their broad ESBL drugs is their anaerobic coverage. So you usually should reserve these for serious nosocomial infection, especially people who had prior exposure to antibiotics. Unfortunately, sometimes though, our ICUs tend to use it a lot higher because they have broad coverage, including anaerobes and ESBL. So, and the person, as I showed you, that proportionality looks sick as stink, and they don't know what's going on. It gets used a little bit more in some facilities. Is restricted, and some others isn't. The new fellows are here. Your internal medicine programs was meropenem restricted.
Yes.
No.
All right, so
No.
it's a variability, and that's what I expected. Probably the Northeast tends to have more restrictions, other places less so, but in general. We don't have restricted, although there's always been calls to do that, but it's going to be hard to do if we do that. And I'd look at Guy as I'd say that. Hard. Ertapenem, the other vestige of carbapenems. It's interesting. When this came out, they didn't know where to put it. They didn't know what to do with this. At that time, OPAT was not a big thing either. This is like 20 years ago. And in fact, when it came out, it had shortage issues and production issues. Now it's used in a lot of scenarios, more for ESBLs, especially once a day to go home, when you don't need pseudomonal coverage. Classic areas like ESBL UTIs, for example, things like that. Realize it does not have pseudomonal coverage. It does not have acid-bacterial coverage. And it's, again, poo-poo for enterococcus as well, in my opinion. All right? It might have a little bit, but I wouldn't count on it. So, but it's a nice workhorse drug. Otherwise, it's great for OPAT when you need to have outpatient antibiotic therapy. I'll put a slew of adverse effects here. Allergies are probably aligned with beta-lactam a lot. And we'll talk a little bit more about that in a little bit. This lecture and the next lecture that I have. Some ceftriaxone has a pseudobiliary lithiasis. It's probably, I only noticed it a few times. I really don't notice it at all that much, and I'm not sure you guys do it at all. You guys use a lot of ceftriaxone out there, and really, it's seen occasionally, but not common. Occasionally, liver enzymes, which beta-lactam is really known for, is liver enzyme elevation as a side effect potentially. It's actually oxazolidine. So, I mean, it's one of those things you really have to remember. All of them theoretically have a small percentage, but that one's more known for. CNS activity, I didn't put it here, but high doses of cefepime, for example, can cause a little bit of CNS confusion potentially, especially if you're using the elderly in high doses. You got to watch that. Every beta-lactam theoretically reduces your seizure threshold just a little bit, and I've always had that concern of using double beta-lactams as really reducing your seizure threshold. I haven't found it to be a problem because we're starting to use double beta-lactams for like enterococcal infections. We use it occasionally for meningitis early on when you don't know what the pathogen is. But I do worry about it a little bit. Out of the beta-lactams, the carbapenems are the highest risk. Imipenem being the highest risk out of all the carbapenems for seizures. And I witnessed many of those when we didn't have meropenem around, when we didn't have the others, and we were using imipenem in our elderly patients, we overestimated the GFR. We were overdosing them, and I've seen several seizures because of that. Also, you got to worry about carbapenems and drug interactions, specifically valproic acid. If you're taking valproic acid to prevent a seizure, and I give you any of the carbapenems I just listed earlier, all of a sudden, 2 days later, your valproic acid goes down about 80 to 90%. So essentially, you're decreasing the seizure threshold. And if you're using valproic acid, you're just giving them a recipe for seizure. So it's something to remember to look for. And we have one of those alerts set up in our hospital for that.
I've seen it. It's terrible.
Monobactam. One drug in the monobactam class is aspirinam. Gram-negative only, does not really have Acinetobacter steno or Burkholderia patient coverage. It has pseudomonal coverage. Really, it should be used for a scenario where the patient has an anaphylaxis history to penicillin, and it's been recent enough that it's still legit, and you still need gram-negative coverage. Other than that, I don't see it, and I guess we'll have one later on our talk where we use it in maybe an NTM population. I mean, a CRE population. We'll talk about that. I forgot about that potential. Quinolones, mechanism of action. Inhibits DNA gyrase, the topoisomerase 4. The synthetic broad spectrum antibiotic. Been around for a long time. I wrote the newer agents. The newer agents is amoxicillin. That has more anaerobic coverage. No pseudomonal coverage. They all have atypical coverage, chlamydia, mycoplasma. So back in my day, there was more abuse than they are now. Why? Because we used them like water, and we didn't realize all the side effects that now that could exist. Unlike the beta-lactams, this is concentration-dependent bactericidal activity, meaning not necessarily over time over the MSC. It's more how high over the MSC. You get a little augmented response. These are dosed either once a day or twice a day because of that reason. They're generally well tolerated, and that's why they were used like water in the 90s and early 2000s. But they also are pretty good drugs to induce C. diff because they really play havoc on your GI microbiome. So the adverse effects, these are some of them. GI is listed, but I don't think that's really an issue I worry about too much. CNS is, again, I've seen issues with agitation. Allergies are uncommon, but they are reported. Photosensitivity is one that actually I do tell my patients if they send them home and if they're going to be on especially in Florida, wear sunscreen, hat, long sleeve shirt, or at least don't go out sunbathing while you're on your Cipro or Levaquin. Prolongation of QTC, everybody has opinions on this. Yes, it does occur. We did not know about we did not worry about this for a decade, and now in this past decade, there's been a heightened awareness of this, and especially if you use, let's say, quinolone and an azole together, you really have to. I think that's when you really would look at the QTC. So for short durations of therapy, I don't look at it. For longer durations, I think you should. Hepatic, I haven't seen hepatic issues with it. I think I've seen 1 or 2 cases of LFT elevations that may be attributed to quinolones, but that's not a common scenario. What's more common, musculoskeletal, the tendonitis. We all know about the Achilles tendon ruptures, things like that. And the potential effects of the aortic aneurysm dissections. I don't know if this is real true or not. It's been really out there in the last 5 years. And I say potential because I'm not sure there's anything really certainly shown that to dissect a rupture. Dilation can occur and progress a little bit further, theoretically, with long use. So, after a couple of black box warnings, these quinolones that were used like water are still being used quite commonly, but a little bit more restricted. All right. Macrolides, another drug that's overused, especially in the outpatient arena, is the Z-Pak. Mechanism of action: this inhibits protein synthesis. Bacteriostatic. You have 3 agents out there. Most there's only PO, but the erythro and azithro is IV and PO. Erythros, I used to use it for treatment. Now it's all used for GI motility reasons. It's rarely used for anything else, even though it has antimicrobial activity. The common uses for these drugs are really respiratory infections, outpatient, some atypical infections, like chlamydia, Lyme disease. And otherwise, I still think Azithromycin is probably overused and abused as an outpatient arena. We don't see as much abuse in the inpatient arena because we've used other drugs. Aminoglycosides work on 30S ribosome unit. So if you talk to my ID pharmacists, they don't like Gent anymore. It's called a gram-negative drug, even though it has gram-negative activity. It's what a gram-positive aminoglycoside. It still covers some gram-negatives, but we traditionally use Topra now for a gram-negative agent. And amikacin is used for those that are resistant gram-negative rods. We used to use these drugs in synergy with solid agents, for example, enterococcal endocarditis. But now recently with ceftriaxone supplanting that in most cases, actually we're rarely using aminoglycosides and use them sparingly in resistant situations, maybe early sepsis as well, because we're not sure with resistance as well. And I think GYN still, OB still uses them occasionally, but it's become a vestige of as well as far as utility, even in the hospital setting.
With the new breakpoints, Toby is pretty much the only one that you can actually you can actually get a concentration for a fraction patient.
And that's why we don't use much Gent. Actually, what helped us actually is a shortage of Gent. And sort of we kind of broke that habit, and now we are mostly a Toby hospital. So like the fluoroquinolones, even more so, this does have a concentration-dependent killing. So they take advantage of that in dosing. One of the pharmacists will talk to you about that later, probably next week, I think, where you have traditional dosing of either Topra, Gent, or amikacin, whereas 2 or 3 times a day, troughs and peaks, versus once daily dosing, or ODA, they call it, one daily dose administration, to try to take advantage of this concentration-dependent killing. Actually increases killing. Even after your concentration goes below the MIC, you have this post-antibiotic effect where you still have activity going on against targeting the organism. And as a result, you also mitigate a little bit of the side effect profile, especially the renal side effect profile of these agents. Only thing I want to see you guys use this drug for is 2 things. Pathogens in the urine and pathogens in blood. Theoretically, yes, there's others, tularemia. There's a few other things, like I guess TBA, you can use streptomycin, but theoretically, those are the 2 areas of the body where you should be thinking, okay, maybe I could use an aminoglycoside, because it gets really poor tissue penetration, really poor lung penetration. It doesn't get 0 CNS penetration, so it doesn't. It's really that's where you really want to. If you have bacteremia, you have a complicated UTI, that you're stuck, this is a potential for you. Nephrotoxicity potentially is reversible, not always, potentially is reversible. But the other ones, the ototoxicity, is usually irreversible. That's when you start seeing people who have been on drugs for like endocarditis, or have been on drugs for, let's say, NTM infections, and amikacin has been used. And all of a sudden you start seeing auditory vestibular problems. It's sad. They have it. It's usually irreversible. It's a problem. It has a known effect. It can cause neuromuscular blockade, especially if steroids are given at the same time in the ICU. Again, its use is so small. I don't see this anymore. I've already saw it before. And it's one of those drugs in myasthenia gravis patients, including quinolones, that you shouldn't use in that population, because it theoretically can cause an exacerbation of their myasthenia. Vancos, you all know about. Impairs cell wall synthesis, the D-alanine, D-alanine cross-linking. Gram-positive, no gram-negative. And yes, the only antiviral you should probably use it against is C. diff in the oral formulation. And it's a workhorse drug. Now, what I need to know, Moffitt, do they do AUC over MIC doses? Or they still do trough-based dosing? The VA, is it trough-based dosing, or do they do AUC over MIC? So TGH and the VA have done that. Moffitt is not. Okay. So Vanco is really concentration independent. It's actually time above the MIC. But better marker is actually AUC, area under the curve, over the minimum concentration is a better predictor of its pharmacokinetics. We usually, no one, I don't think in any facility we dose vancomycin anymore. TGH, we stopped doing that about 4 or 5 years ago. We were dosing people. So I remember to load the tank, meaning that you had to give a loading dose. And the old strategy, and the strategy I still think is used at, I guess, Moffitt, is you keep the concentrations above, the trough concentration above 10. Theoretically, if there's sicker infections, worse infections, 15 to 20 is a target concentration. Now, like I said, now there's more emphasis on AUC or MSC. The data on that is really MRSA. There's not as much data in non-MRSA using this schematic or this type of dosing. And I think that data is coming. I mean, it's being used a lot of places. There's algorithms and formulas, and at TGH we bought a system to help the pharmacists figure out how to do this. And their target AUC and MSC may be somewhere between 400 and 600, depending on the type of infection you're dealing with. You just need to be aware of, because you're going to be dosing this. I don't know if any community hospitals you'll be dosing this way if you guys go out there, but I think most of the places now, pharmacy is dosing vancomycin. I think we were probably one of the last ones at TGH to stop doing that. Back here, we go. Adverse reactions, nephrotoxicity, a bit overblown. Yes, Mississippi mud. Everybody heard about Mississippi mud. That's what it's called. I think it was in the 60s. The sterility of how they were making vancomycin was not that great. Toxins cause nephrotoxicity. If I give vancomycin with a nephrotoxic agent, probably has some additive effect to that underlying nephrotoxicity. So you have to worry about that. The other big thing you have to worry about is what's not politically correct now, red man syndrome. We don't call it that anymore. We call it vancomycin infusion reaction. People call it, I've turned beet red, itchy. As soon as they stop the drug, I got better. If you hear that, there's no allergy involved. That's an infusion reaction. That vancomycin is still in their system, but they're not having any reaction anymore. It's an infusion rate dependent, related to histamine release, a lot of itchiness, blushing. Some people get really tachycardic and can even get a little bit hypotensive. If they have a problem, many times we challenge them with this. We just have to go slower. And sometimes you get pre-medicated with Benadryl. Where do we see this most commonly? In the ED. ED is all about rush, flow. The flow goes faster than it should, and this happens. I'm not taking that drug again, and you have to convince them that it was an infusion reaction because it was going too fast. A slide I have in this lecture and the next lecture is antibiotic site and site penetration. You notice that skin is all antibiotics get in the skin, except for the one I mentioned earlier, the aminoglycosides do not get in the skin. It's easiest to study that, easy to get to market with that, and that's why most do. But there's certain things you have to remember, like clindamycin, no urine, no CNS. Daptomycin, don't get in the lung, and we'll talk about why that in a minute. And it doesn't get in the CNS, too large of a molecule. It's also not a great CNS drug, so we have it up here. Those with pluses mean you have to have higher doses in the CNS to treat these. All right, but remember, that's something else we also think about when we're prescribing. And in fact, 15 years ago at TPH, anything that was on the VACTEC card, we used to put in every susceptibility on the report. We realized, wow, why are we putting what happened to be a staph in the urine? And Clinda was on there. It's like, why are we putting Clinda as a urine culture? It doesn't work. And in notoriously, we had a new intern, somebody write Clinda for UTI, and we had to educate them and whatnot. So we actually now stopped that. Next part, this is the part of the lecture that gets a little bit more as far as newer drugs and drugs that sometimes we don't use and may not use. So first, we're going to go with some agents active against more resistant gram-positive agents. The beta-lactam-beta-lactamase we've already talked about. Again, we use it more as an MRSA drug. The next ones are glycopeptides. We'll talk about those. We'll talk about daptomycin, linezolid. We won't talk about delafloxacin. It's actually a new CAP drug. And why don't we use it? We had great cap drugs out there, but this is like 10, 20 times more expensive. Why are we going to use it when you have good drugs out there? The famulin is also a mutilin. It's a different type of mechanism, also for cap. Again, same problem with it. It's out there. It's FDA approved. I'm not sure how if it's being marketed at all. But you're not going to use it because its cost right now is too high. And then the last drug, it's gone. Sinusid. Quantiburstin dalbavancin was my go-to VRE drug. When we had VRE, we had no agents against VRE when this agent came out. This was our salvation, except for the patients hated it. Big time phlebitis, big time infusion reaction, and they puked, they got sick. So it was great if they were sedated and intubated and you could use it, but if they were awake, you were making them miserable. So we have better VRE drugs, and this has gone by the wayside but it was our first real VRE drug that we had to treat patients at the time. So let's go through some of these. The glycopeptides, telavancin, dalbavancin, or ridavancin. Basically, Vanco Plus. All right. Similar mechanism action and spectrum as Vanco. Gram-positive. They're basic glycopeptides. There's lipoglycopeptides. Telavancin is like Vanco on steroids. It's daily dosing. Has a little bit better activity. You're paying it with a lot more cost, and that's why you don't see it in the hospitals, because of the cost. Dalbavancin and oridavancin have extended duration of activity as far as dosing. Dalbavancin could be weekly. Oridavancin, theoretically, one dose covers multiple weeks, a couple weeks. Again, why are we using this more often? Several $1,000 a dose, potentially. And does that go to the patient? No. Your patient in the hospital setting gets billed a DRG, or the insurance gets paid via whatever a DRG. So no matter what it costs to treat that patient, that's the only thing the hospital's going to get. So why are they going to spend much more money, 50 times more money on one agent versus the other if it's going to be the same money and it's as effective? So what we've done, I know that the VA has DABA, and I don't know what kind of funky pricing scheme you guys got to get DABA, because all right, because honestly, it's not cheap. It's not cheap. We've done at TGH. We have a DABA program where TGH will pay for this for patients who are stuck in the hospital with gram-positive infections, or specifically IV drug users, homeless people who can't get patient a sniff, and the gram-positive is the only thing they need. We have a process where we can do that as an outpatient as well. And TGH eats that cost because it's easier to eat that cost to keep them in the hospital for 4 to 6 weeks. Daptomycin, we all know daptomycin. We should all know daptomycin by now. It binds to cell membrane in a calcium-dependent fashion. Okay. Gosh. Resulting in depolarization of the membrane, and basically you have a cell that's dead. All right. Activity against staph and enterococcus, including VRE. Although remember, VRE, you have to use higher doses. You can't use 6 mg per kg, 4 mg per kg. You have to use 10 mg per kg, things like that. No activity in the lung because the surfactant inactivates it. It gets there, but the surfactant says, doesn't work. So theoretically, I guess it could work in the parenchyma of the lung, but not in the alveoli where the surfactant's at. And it's such a large molecule, it really doesn't get in the CSF that well. The one thing you need to remember as far as side effects, we measure CPKs weekly because of potential about 2% chance of myositis CPK elevations. And there have been rare reports of eosinophilic pneumonia. I think I've seen 2 cases. And that's it, not many. When you see it, you'll know it because you've tried everything else and you realize, okay, that's got to be it. And it goes away as soon as soon after you stop it and you start steroid. Oxazolidinones, I can't even say that word. Just call it linezolid. There's 2 drugs in that category, linezolid and tadalafil. All right. Inhibits the initiation complex at mRNA, or stops protein synthesis. Again, has great gram-positive coverage. Staph, strep, enterococcus. Also has some coverage against some of our funky organisms, the nocardias of the world, and certain mycobacterial species. Excellent oral bioavailability. Excellent. Side effects you need to know is the serotonin syndrome, especially. You gotta watch what your drug interactions are with maybe an MAO inhibitor, which I don't see anybody on an MAO inhibitor. And SSRIs, theoretically, I still use it. I watch for it, but you got to watch for the potential of serotonin syndrome in that population. Thrombocytopenia is one of the is a common scenario seen usually near the second week of therapy, near the end, the second week of therapy, if it occurs at all. What worries me is the last two, the optic neuropathy and peripheral neuropathy. Start seeing those, almost too late. Not really reversible. Or at least the ones I've seen have not been that reversible. And that's why we don't use this long term. Now, we are starting to use it long term in some of our mycobacterial infections, and I started worrying about this possibility. And so I'm a little leery of its use long term. And usually I'm okay 2-3 weeks. I don't try to push it beyond that unless I'm really monitoring that patient. I've seen a couple of cases of lactic acidosis theoretically could occur with Linase. It's one of those that you can see lactic acidosis just from the drug. It's very uncommon. So this is the cost from now 2 years ago, but average wholesale cost of 2 years ago. Why are we using certain agents? Why are we not using certain agents? Look at the cost. Vancomycin, cheap. Now that's not counting the drug levels. So yeah, you add the drug levels potentially. Sertraline, 20 times that. So that's why it's held in reserve. The nasal, that's amazing. That used to be $100 or $200 a day. Goes generic, boom, look at that. That's why we use it. That's why we had no problem using it in the hospital setting. Today's however, is still under not generic yet. And look how expensive it is compared to linezolid. Dapto, again, cheap. It used to be $500 a dose. It's now $25, $50 a dose. Much better. Dalavancin, look at the cost there. Dalavancin, Oretavancin, and then the two drugs I talked to you about, CAP, no one uses it because look at the cost again. Cost does matter to a certain degree. I mean, especially you understand, I do know medicine, but it's also medicine's a business, and that's why I kind of need to get an idea of the perspective of the differences in cost. And as I showed you, the change from Dapto and Linase downward after they were the costly drugs 10 years ago. Gram-negative resistant agents. Colistin, I'm just going to mention here. Hope we don't have to use it too much anymore. If you're from the Northeast, about 5, 6, 7 years ago, you used a lot of it before those last 5 drugs you see on this list came around. Because that's what we used to use when we had nothing else for our CRE populations. Don't see it much used anymore. Has anybody used it recently? No. You probably still at some point may have to use it. We will probably have to use it at some point because these last 5 drugs, they're not invincible either, right? So I leave it in there. We'll go through each of the other ones in a second here. Tigecycline. The glycopeptides, maybe similar to minocycline. Minocycline we use POIV and we use it all the time. It's an indication of skin and soft tissue and intra-abdominal infections. When it came out, all the surgeons started using it for their belly infections and whatnot, and used it left and right. And their patients started feeling crummier and crummier. And it's one of those drugs. If you want to make someone sick, GI sick, that's a good drug to choose. Bellyache, nausea, sometimes vomiting. It's not so much diarrhea, but it can occur. But mostly the upper stuff and the belly pain. What we use it more now is mycobacterial NTM infections. And we try to use it in lower doses than we've traditionally used it for bacterial infections. So we kind of get away with the mycobacterial infections. And it kind of does that. The side effects are kind of dose dependent. So you kind of get away with it a little bit. But still, some people, even in the lower doses, have a heart. So it's one of those drugs that's still around. It came out as one thing, and now it's being used more as a mycobacterial agent. The other tetracyclines that we hear about, don't use often, and not on formulary, I don't think any of the facilities, but we've used omadacycline, for example, DGH, non-formulary. These are agents that are used against more resistant strains. Iridocycline is a little bit more potent. And omadacycline, we've used mostly, I think, because of an NTM infection that actually had resistance to tigecycline, or the patient intolerant to tigecycline, and we're able to use omadacycline. Again, there are other type of tetracyclines that are available. they try to be used for either CAP one or intra-abdominal infections, but the reality is, I think they're mostly being considered in these weird scenarios where you have mycobacterial infections. It's interesting. Companies think one way, and in reality sets in, and where they fit in therapy in clinical practice another way. Cephalosporins, tazobactam, Zerbaxa. All right. When you hear this drug, you think, well, it can cover some theory. Think Pseudomonas. This is a pseudomonal agent. When you see your regular panel are resistant to everything, or nearly everything, call the lab to see if they can test for this agent. Has increased activity against Pseudomonas, especially those who have overexpressing AMP-C and efflux pump resistant mutants. It was studied to get the FDA approval in UTIs and intra-abdominal infections when given with metronidazole, but obviously this is a Pseudomonas agent, and I've seen it more used for, let's say, a chronic driveline, a person with a ventricular cystitis has chronic Pseudomonas driveline infection, that they use Cipro, that they use Cefepime, that they use Zosyn, that they use Meropenem, and then eventually they're all resistant, and then this is next. And someone who has destination therapy of that in place. Things like that. So we see this occasionally. The other place we see this in the respiratory infections are Pseudomonas that we in our ICUs treating, whether because a patient has bronchiectasis, lung disease, or they're just colonizing. We just keep throwing things at them, and eventually they need an agent. And yes, I've seen resistance to Pseudomonas to this agent as well, where there's nothing. So you can blow through this as well. Next agent, ceftazidime-avibactam, or brand name Avicaz. We all know ceftazidime, gram negative only. This is third generation cephalosporin. It's the avibactam that's the important drug here. It's a synthetic beta-lactamase inhibitor. It inhibits ESBL, MCs, KPC, oxa-48 carbapenems. It does not do anything against the metallo-beta-lactamases such as NDM1 or VIM. However, look at the last bullet point. If you combine it with SGNM, it does. Only if you combine it with SGNM. That's the other role for SGNM that I mentioned earlier, is in this scenario. Mainly used in CRP infections. And it's one on formulary at TGH. I'm not sure what's on formulary at the other sites. Other for CRE drugs, Meropenem, Vaporactam, brand name Vapomir. The Vaporactam is a cyclic boronic acid beta-lactamase inhibitor. It works against classes A and C, mainly a KPC, so it's mainly a KPC agent. It also does not inhibit metallo-beta-lactamases. It doesn't attack any of the OXA enzymes as well. And I add, again, just because you add Vaporactam, it does nothing for Pseudomonas. So if you have Pseudomonas, it's resistant to Meropenem, and someone tries to use Vapomir for it, it's idiotic. Vapomir does nothing for that. So there's no real enhancement in the Pseudomonas coverage. Imipenem. What's the brand name here? I forgot this now. I know it. I gotta remember it. It's also another KPC type of drug. It activates against KPC carbapenems producers, including KPC2 avibactam resistant mutants. Does not work against metallo-beta-lactamases. Or any OXA-23 or OXA-48 carbapenems. Last agent we'll talk about, and then we'll show a summary slide. Cephalosporin. Actually, so therefore, cephalosporin. So it uses iron in its pathway. I keep forgetting how it does that. It's very broad spectrum. Works against all the interbacteriales. Has Pseudomonas activity. So even after the Zerbaxa, we've actually gone to cephalosporin on some agents. Some places. Acinetobacter, Pseudomonas, great. Doesn't have good anaerobic activity. Does not have really good gram-positive activity. It's really a gram-negative agent. Has a little bit of activity against the metallo-beta-lactamases. So this in itself can be used against NDM isolates, against the VIM oxalates. But it's not invincible. Some resistance has been noted as well. And actually, interesting, in a trial, I think it was Credible. I can't remember. It was a Credible trial. They actually had a combination of using this agent versus available best therapy that the prescriber wanted to give, and it's usually combination therapy. actually did not do as well as far as mortality in Acinetobacter infections and in certain bacteremias as well, and nosocomial infection, pneumonia. So while it has spectrum, you wonder about the mortality benefits of this, and that's why it's like, I don't know. And you start questioning it, and everybody starts questioning it because of that study. There's gonna be it's gotta be a question on your boards on this. It's not one or two. It's not gonna be a question like this, but it's a question about this. Let's start on the bottom first. The metallo-beta-lactamase, the bad boys, the worst boys. These are the NDMs. What are your therapy options here? There's currently only two. Cephalosporins or the combination Astringent and avibactam ceftazine. In Europe, I think they already have the drug that's a combination of avibactam and Astringent. I'm not sure if, when, and how, if they're going to come over here, because we don't need ceftazine here. We just need the avibactam. That's why we combined it. That's metallo-beta-lactamases. That's your goal. Go all the way to the top now. Your resistance to Pseudomonas. You know, you've gone through your merums, your cephalosporins, your fluoroquinolones, your zosins. Your options are basically Zerbaxy is your best option if it's susceptible. If it becomes resistant to that, you might have avibactam. You probably don't. You probably lost at the same time. You might have cephalosporin, and that's the way I will go there. Your KPCs, you have three options here. I know he's a very guy.
Only for KBC.
I'm an Avicaz guy. Just because it's on formulated, so what I've used. I've not used the other two. Relobactam. Relobactam's the imipenem. So those are the agents you could use. Those three. Any of those three you could use. Those are KPC agents. If you have a test question and for some reason it gave you Oxa48, you really have two options. Your best option, the best answer would be Avicaz, ceftazine and avibactam. Remember, the credible trial, the protocol is your second option, but the credible trial, the mortality, we start questioning whether that's really going to be as effective now, even though it has activity. So you got to remember this. There's a reason why we have it restricted to ASP only and TGH, because it's a lot to remember here. And we want the pharmacist to go over with you. They're the ones that usually find out about the resistance pattern before you do. And so they're the ones probably calling you, and they're writing the order, but they might make sure you're okay with it. That's the way we do it at TGH. I'm not sure it's done at Moffitt or at the VA with these agents. But that's how it's done at TGH. Guarantee you're going to have at least one question on this. The cost of these gram negatives, cheapo cephalosporin, cheapo merum compared to the rest. All right? Tigacycline, relatively inexpensive, but gives you a lot of GI side effects. Look at the bottom five. These are access less than $400 a day. All right. Look, cephalosporin, $1,000 a day. Avicaz, $1,000 a day. It's expensive as well. And yes, that's why we don't use these up front for obvious reasons. We don't want to cause resistance, but we also don't want to break the bank. And these are hard, they're nearly impossible to get done as an outpatient. So if you want to send someone home, very difficult to do because their infusion times are difficult and prolonged, and no nurses want to sit around for 2 or 3 hours waiting for the infusion to get done. Last slide for this is potential new agents. Scary agent is not approved yet. It's approved in Japan. Tebipenem, oral carbapenem. The pro drug becomes carbapenem. It's great if you think about ESB or UTIs and send home on pills. Oh boy, the potential for us stewardship people, the potential for abuse is outstanding and scary. And then the drug that is approved already, sulbactam and durlobactam, it's FDA approved since last year. It's a drug for one bug. It's a drug for Acinetobacter, for those carbapenem-resistant isolates. You're supposed to use it, I guess, in conjunction with imipenem. I know no place that has it on formulary, and if we would use it, we would use it on non-formulary requests. We have not used it yet, but it's just one drug for one bug, so to speak. So that's the summary for this first part of the lecture. which have gone different far than I thought it would. Resistance increasing. Use the drugs carefully. Use your pharmacist if they know what they're doing. They'll help you out. They talk things through with you. They do it with me all the time still. And think, evaluate probably before prescribing.